Hey guys, so I'm just going to be talking to you about treatment protocols for extensor tendon injuries. This is the contents of everything that I will be going over. So just for a quick review of the extensor tendon zones of the hand that we learned in Kines, there are 8 zones from the DIP to the distal forearm, 4 thumb extensor zones, each of which is associated with a bone or joint of the hand or upper extremity. Later, I will go briefly into injuries of zones 1 and 3, and more in depth with zones 5 and 6. In general, extensor tendon injuries are more common than flexor tendon injuries. The most frequent causes of injury are laceration, overuse, and trauma. It is likely that these injuries are more prevalent because of the anatomy of the area, for the tendons are very flat, superficial, and have no protection from subcutaneous tissue. Injury management can be completed in 3 ways: non-operative, primary repair, and surgical tendon grafting. Overall, the main goals of healing is to restore smooth functional movements of the hand with no adhesions or gapping of the tendons. As discussed in lab previously, some deformities of the digits include boutonniere, swan neck, and mallet finger. This could be due to a condition like RA or other trauma. Mallet finger often occurs due to forceful flexion of the DIP, causing damage to occur to the extensor tendon in zone 1. There can be many design options for the FO to keep the DIP stable. Boutonniere deformity often occurs when someone jams their finger, causing DIP to hyperextend. This leads to a torn extensor hood, leading to the lateral bands to shift volarly in zone 3. Swan neck injuries lead to weakness of the volar ligament, causing hyperextension of PIP and flexion of the DIP. Here, the lateral bands can shift dorsally in zone 3. A common orthosis design of both of these deformities would be an oval 8. Before I review my evidence, I want to address 2 possible perspectives of clinical treatment protocols. First off, one perspective recognizes these options as being static or dynamic orthosis designs. Additionally, the associated movement protocol can be vital to recognize as well. By this, I mean either immobilization, early passive motion, or early active motion of a rehabilitating joint and tendon. These terms will come into play later. This first study compares 2 orthosis rehab methods to help repair function in extensor tendon zones 5 to 7. There were 52 participants with 83 injured digits total, all of which had either complete or partial lacerations greater than 50%. 25 of these individuals were provided a static volar WHFO extending to the middle of the proximal phalanx. This placed the wrist in 30 degrees of extension, the MCPs in 45 degrees of flexion, and the IPs free to move. 27 of these individuals were provided a dynamic MCP extension dorsal orthosis. Passively, the rubber bands held the MCPs in extension, but also allowed for 30 degrees of active flexion. The static group began a progressive range of motion program after 3 weeks, while the dynamic group was initially instructed to begin range of motion tasks each day. Outcome measures were placed at 4 weeks, 12 weeks, and 6 months to assess active range of motion, total active movement, particularly for an extension leg, grip strength, and dash scores. By the end of the study, the dynamic orthosis group improved their total active motion, grip strength, and dash scores more than that of the static orthosis group. Many factors could have contributed to this, including the associated motion protocol. The second study reviews the rehab perspective of movement protocols of extensor tendon repairs of zones 5 and 6. There were 27 participants recruited initially and required tendon repair. Some of these individuals dropped out of treatment, so outcomes were based on a total of 24 digits. 5 were following immobilization protocols with a static splint. This placed the wrist in 40 degrees extension, MCPs in 20 degrees extension, and IPs neutral. 8 were following the early passive motion protocols with a dynamic splint. This placed the wrist in 45 degrees extension, MCPs in neutral, but allowed for 30 degrees of active flexion. 11 followed the early active motion protocols with a static palmar block splint. This placed the wrist in 30 degrees extension, and the MPs were blocked at 45 degrees. The IPs were free to move. Outcome measures were taken after 3, 6, and 12 weeks to address self-reported functional capacity using a 10-point visual analog scale, extension lag, total active movement, and grip strength. By the end of the study, all groups have been successful in making progress, but the early active motion group improved the most, particularly when reviewing their range of motion, minimized extension lag, and overall function. The previous study reviewed the extensor tendon treatment protocol post-op. This case study addresses one method of surgical management after an injury to zone 5, otherwise called a fight bite. This is the most common mechanism of injury to this specific zone. The individual focused on in this case study is a 37-year-old male with a laceration to the dorsal aspect of his right hand in digit 4. He did not seek medical attention until 6 days after his injury. Initial assessment found that the patient developed severe pain, limited range of motion in extension, significant edema, and erythema at the area. Over the following week, he received 3 surgeries to debride the area, determine how large the extensor tendon laceration was, and harvest a tendon graft of palmaris longus to connect the 10-centimeter extensor gap. The right side of this slide shows the appearance of his hand post-op. If it interests anyone, below that image is what the tendon reconstruction looked like during the surgery. Following this procedure, the patient was seen only 3 times in therapy. He was unable to attend 2 follow-up times due to limited transportation access. Week 1 found moderate edema of the affected areas. He was provided with range of motion exercises to complete each hour and a block splint otherwise. Week 6, the patient had no MCP extensor lag, but 30 degrees of PIP extensor lag. He also was unable to make a full fist due to stiffness in the area. Again, he was re-educated on rehab protocol for home exercises. At week 12, his PIP extensor lag was reduced to 15 in digits 4 and 5, as seen below. He was also able to make a loose composite fist. He found these results satisfactory, and it was positive that he did not experience any adhesions or further infections. Now, each of these studies can definitely relate to OT practice. If you encounter an extensor tendon injury while practicing in the future, it will be important to recognize the differences in evidence for orthoses and movement protocols. Also, recognition of client factors can impact the success of all protocols. More on that later. The case study also showed how it is important for us to be holistic practitioners to recognize and care for all physical impairments. This includes providing the client with the best treatment methods for home programs. Overall, extensor tendon injuries are very common. A clinician could encounter this impairment in many settings, including a hospital, if directly post-op, outpatient if during follow-up from a surgery, or initial eval for more distal zones, hand clinics, or within the pediatric population. Specifically, there is evidence relating to children's extensor tendon injuries and rehabilitation. Considerations need to be made for their smaller anatomy in the associated zones. On top of that, the likelihood for more immobilization protocol being used with splinting and casting is increased, for it encourages more compliance and a speedy recovery without tendon rupture. Overall, it is positive to have some awareness of these injuries in your back pocket. In future studies, it would be beneficial to see more comparative research related to treatment protocols with larger groups assessed and also assessed for longer time periods. For viewing functional levels over time could provide further insight to treatment success. Also, future studies should review more individuals with extensor tendon grafts to determine success in treatment and surgery outcomes further. It could also be beneficial to track more rigorously the exact exercise and orthosis protocols provided to each patient. Overall, a focus on updating the best practice treatment for extensor tendon injuries of zone 5 and 6 would be beneficial, since many articles identified a gap in consistent and accepted protocols. Now, the discussion questions that I have for you guys are as follows. What client factors or precautions would be important to consider when determining treatment protocols for a patient with an extensor tendon injury? And then the other part of that is what would make you consider a custom versus a prefab orthosis? Also, what interventions and modalities would you consider implementing with a patient with an extensor tendon injury, and why? Thanks for listening, guys. If you have any questions, just ask me in the forum.